presented by Dr. Jing Wang. Dr. Jing Wang is a board-certified psychiatrist in Long Island, New York. Dr. Wang was born in China, and she obtained her undergraduate degree from CUNY Lehman College. She earned her medical degree from St. George University School of Medicine. She then completed her residency training in psychiatry at Maimonides Medical Center, both PGY1 and PGY2, and University of Medicine and Dentistry of University at Cooper University campus. During her training, Dr. Jing Wang was selected to be chief resident twice as a third and fourth year resident. During her training, she was mentored by some of the most skilled psychoanalytical and psychodynamic psychiatrists, children and adolescent psychiatrists, in addition to addiction psychiatrists. After graduating from resident training program, Dr. Wang has worked as an attending physician in a 40-bed inpatient psychiatry unit at Maimonides for 8 years before she started work full-time in New York State Psychiatric Center Clinic since 2016. Dr. Jing Wang also has a private practice. He runs on weekend, in addition to being a mom for 3 teenage children. Thank you so much, Dr. Jing Wang, joining us today. So we invited Dr. Wang to attend our annual convention because I'm a primary care doctor. We have the challenges of managing the psychiatric patients in our community on a daily basis. They will come to us with some feeling anxious, feeling depressed, and we always a little bit not feel so confident to start the medicine. So we invited Dr. Wang to give us a talk about how to manage psychiatric disease. I'm pretty sure me and other colleagues will going to learn a lot from Jing Wang's talk. All right, thank you so much.
Good morning, Dr. Wang. Good morning, everybody. Thank you for that warm introduction. Okay, so I was asked to give a little bit talk regarding psychiatric illness for primary care doctor. Everybody hear me okay, right? All right, we're gonna actually cover, let's see, you're learning how to use this. Okay. All right, so we're going to mainly cover 3 things: depression, insomnia, and anxiety, and when to refer to psychiatrist. Got it. Okay, so we're going to do the case 1. I'm going to try to also keep my time on time to the next presenter. So put the timer up. Here we go. A 60-year-old female comes to see you, report feeling very depressed after her husband of 30 years, excuse me, passed away from cancer 4 months ago. She can't sleep at night, she's crying, and she told you she couldn't take care of her grandson, which she spent the time during the day. She's asking you if this is normal. She's on metformin for diabetes 2, and she's on, I believe, a blood pressure medication for hypertension. So pretty typical case, right? People come in, feel comfortable with their primary care doctor, says, hey doc, this is what's happening with me, but otherwise I'm okay. So what are we dealing with? Are we dealing with depression, right? Feeling sad, anxiety. She didn't really say that she was worried, but it's like have this ender feeling of what's going to happen to me now that husband is not here. Should I stay in here? Should I go back to China? Insomnia, sleeping is a big issue. Normal, is this a normal grief reaction versus complicated grief reaction? We're going to talk about how to hallucinations, Is this, to answer the patient's question, is this normal? Do I need medication? So first, let's talk a little bit about depression. Right, so this is for psychiatrists and bread and butter, but for PCPs, basically this is the DSM-5 criteria, right? For depression, you need a 5 out of 9 symptoms, right? For certain, for the same 2-week period, and at least one of the symptoms has to be either very depressed mood or loss of interest or pleasure, right? Or patient girly take care of her grandson, and now she said she doesn't feel the joy when she does it, and sometimes she's wondering if she can even do it, right? And there's a list of the 9 things we're looking for. Basically, it has something to do with sleep, with eating, their energy level, their concentration, and their feelings of their worthlessness or guilty. Like the most important thing is number 9. If they have any suicidal thoughts, suicidal ideation, then do they have any plan? Do they have any intent? And those are the symptoms are not due to attribute to another medical condition or substance use, cause significant distress impairment, right? This has become a very important thing when we decided do we need medication, their impairment. And sometimes the response to significant loss, like in this case, the husband passed away, could be very understandable, but you need to use a clinical judgment to see if there are actually a major depressive episode on top of the regular response. Okay, so this is something that in PCP's office we use a lot. I believe Dr.-Jing, GP Chen, who is the legend in our field, I believe he put the PHP-09 in Charles Wang Clinic, right? So this is a very quick questionnaire, and if you could just look at it, and the score actually tell you the level of the depression. So this is a sample of a PHP-09 depression questionnaires, and I see a lot of people actually put on their in their screening tool now. And basically is a list of those 9 symptoms, and you score them with the scores. And look at the bottom, where 5 to 9 will be mild, right? 10 to 14, 10 to 20 is about moderate. There's a moderate, and moderate severe, and above 20 is severe. Why this is important? Because this gives us a guideline in terms of medication. What's important is I tell my PCP doctors, it's not just lack of sleep. It's not just sleep too little, but also sleep too much, right? Not just you have to, in terms of sleep, we ask very, very detailed question, right? Is there a problem falling asleep? Is there a problem staying asleep? And it's not just the weight loss, right? When people think about depressed patient, very skinny, not sleep well, and very low energy, actually you also have to ask about weight gain, right? We have some marks there, 2 pounds, 5 pounds. And the suicidal thoughts, which we said, this is the most important, right? There are never, or patient would say, well, no, I never saw it. I have my children, how can I even think about it? Or sometimes passive. They felt that life is not really worth living, but they don't really have any active plans. If they do have a plan, do they have intention? Do they have actually not just the thoughts, do they have, a very specific plans? And is this happens several times a week or several times a day, right? All right, then this is again about the mild, moderate, severe, right? A key to remember is when it comes to moderate, there are possibly suicidal or homicidal thoughts, right? In our case, there's a cake involved, right? We're gonna talk about that later. That makes the picture a little bit more complicated with the adult dealing with an underage child at home alone. For severe, has to be 7 symptoms, plus either psychotic feature or catatonic feature or marked distress or functional impairment. And the reason we do it because the severity, the different level drives, the medication drives our plan. This is actually a very important slide. So in this slide, this is American APA, American Psychiatric Association's recommendations, what to do when there is someone, a patient reports to you feeling sad, feeling depressed. You can see when you have those 3 criteria, when there is an imminent risk of harming self or other, that's actually with a plan, with the intention, actually we recommend 911. That needs to be dealt right there, right? But if no, right, if it's yes, you go to emergency department. We'll talk about psychosis. We're gonna talk about a little bit about catatonia, right? If any one of those 3 is a yes, that's an emergency. If it's no, what you do is that you're gonna, depends on the degrees of functional impairment and duration and how long and the number of frequency and intensity of the symptom, right? We talk about mild and what we need to do. And in terms of just the mild, right, with the MHQ numbers, and you can decide if this has never happened before, there's no history of depressive episode, or symptom is less than 3 months. You actually can do what we call active surveillance. You see the patient 2 to 4 weeks later. You observe, right? And then we'll talk about supplement intervention. We recommend lifestyle change, exercise, yoga, or but when they come to moderate, we talk about that. MHQ-9 is 10 to 19, and there is possibility of suicidal thoughts. You do psychotherapy or antidepressant. Actually, treatment shows you do both combination, right? And of course, you always including supplement interventions. When it's severe, when the PHQ-9 is more than 20, you do psychotherapy, you use antidepressant, but the medication is a little bit different. It's not just the SSRI, you're adding SNRI. We'll talk about that later, which one you should use. And you should always add supplemental intervention, right? Everybody can benefit from some exercise, yoga, Tai Chi. So we talk about this active surveillance. You should see patient 2 to 4 weeks to monitor the symptom, and supplemental intervention. We talk about yearly use adjuncts to active surveillance, such as antidepressants, psychotherapy or combination, exercise, self-help, groups online, mind-body intervention like yoga, Tai Chi, and the bright light therapy. Okay, so we talked about this as a sort of review. I think the question probably our PCP doctor want to know is what to use, right? What medication to use. So this is it. So usually they're recommending, APA recommending is Lexapro, which is acetylcholine. I'm sorry, the slides went up a little bit, and the sertraline. So Zoloft and Lexapro, Zoloft, Lexapro, Zoloft, Lexapro. You will see that for depression, but also later on for anxiety too. And SNRI, that's more for severe MDD, major depressive. We use venlafaxine, which is Effexor, or duloxetine, right? Cymbalta for severe MDD. SSRI are reasonable alternative. Sometimes you use both, but I think at that moment when you have to use both, probably already refer to psychiatrist. This is a very busy slide. this is actually this is a side effect of the medication we just talked about, but I want to make sure that just a couple of things that you should know. One is all the SSRI cause sexual side effects. This is very important for your patient, right? Maybe not for our patients who just lost their husband, but for the younger group, for people who are sexually active, this is very important. The other thing is the QT prolongation. We just had our cardiologist talk about that, and you need to keep in mind, Celexa can cause QT prolongation. We do not recommend to go more than 40 milligrams a day. And the other things is SNRI, right? Serotonin, norepinephrine reactive inhibitor, bupropion, which is Wellbutrin that you use a lot. Like, you always want to use the extended release rather than immediate release because causing agitation and insomnia. When in doubt, use the extended release when it comes to Wellbutrin. And now, one of the medication we use is mirtazapine, right? Remeron. Remeron, you need to know, can cause severe drowsiness. So patients driving, this is a medication you want to tell them to start on the weekend to see how they feel, right? And Remeron can cause significant weight gain. That you have to keep in mind. These days, people want to look beautiful, look thin. Okay. So venlafaxine, I wanted to talk one line about Effexor. Venlafaxine has a lot of withdrawal symptoms. I have a patient, she forgot to tell me, and she ran out, and she said, I called the doctor after the weekend. She ended up in the emergency room for palpitation. It's not listed, but I've seen quite a lot of withdrawal from Effexor. And we don't really use too much tricyclists or sometimes I think if patient visiting from China, they might have some medication we don't usually use. But frankly, here in the US, we don't really use much of tricyclic. All right, so we talk about this. First line is SSRI. The key points, earlier treatment is more effective. So that actually says a lot because I spoke with the psychiatrists in the community. My feeling is sometimes by the time they got to the patient, they use the higher dose. They use more than one medication, but it's hard. So there's a feeling that the earlier treatment, the better. Psychotherapy works, right? Sometimes, like I have patients that I don't want to be on any psychiatric meds. Absolutely, psychotherapy should be tried. We can do interpersonal therapy, cognitive behavior therapy, problem-solving therapy. Some are very short term, 8 to 16 weeks. SSRI, SNRI can transiently increase anxiety, agitation, and or irritability. That need to let patient know because they might feel actually a little bit anxious when they start the meds. For young adults, we know there's a black box warning about increased suicidal thoughts. The feeling is that sometimes people are so depressed and they don't really feel like doing anything. They don't have the energy. When you start giving them SSRI, that beginning there's a boost of energy. They're actually able to hurt themselves. They are able to carry out the suicide plan. So you do have to be very careful. With depressed patient, it's the suicidality should be assessed at every session. Timing taper. Symptom improvement can occur as early as 1 to 2 weeks, but in general, SSRI can take 6 to 12 weeks. So we're talking about 3 months. And antidepressants should be tried at least 6 months after symptom return to baseline. The patient tell you, great doctor, you gave me the Zoloft, it really works. I am at the 50 milligram, you start at 12.5, and we increase the 25 in 2 weeks, and now we're at 50, I'm doing good. So when can I stop? So the answer will be 6 months after you return to your baseline. Early discontinuation of antidepressant can increase the risk of relapse. Now, there is a mark of if they try it on more than 2 weeks, you should taper the dose. However, if you give somebody and they call you 3 days, I don't like this medication for whatever reason, make me nauseous, make me not feeling like myself, you can absolutely stop without tapering if it's less than 2 weeks. So back to our patient. So our patient said she's feeling sad, she lost the interest, she really enjoys such as taking care of her grandchildren, and she cries all the time. So our diagnoses are mild depression. Right? There's no catatonia, there's no psychosis, right? When we talk about psychosis, we talk about hallucination, delusions, right? Hallucination, clear voices, when no one was there. You ask her, do you hear your husband? When you miss your husband, what is it like? Does he visit you? Do you see him? Do you hear him? Do you, and if, you know, it depends on what she said, right? It's one thing to miss somebody. I see him in my dream. When I'm about to fall asleep, I felt sometimes he's here too, like he talks to me. He's inside me. He's, you know, you will decide it's a hallucination, or is this a normal reaction? Right? No need for ER referral at this time. There's no suicidal thoughts. Patients said, I'm not suicidal. I don't want to hurt myself. I've never had any suicidal episode. I've never been depressed like this before. So that's right there. And is this a normal grief? This is within 6 months, and no psychosis, no suicidal thoughts. So we say this is normal. So the next question is talk with the patient. Does she think she needs a medication? I think from what I hear, from my experience, most of the patients either they want to wait, or there are people said, well, give me something so I can continue my daily living. It's really about impairment of their functioning level. I think that's very important. So you probably chose Lexapro or Zoloft, right? And it works very good for depression, anxiety, and if all possible, to refer the patient to see a therapist. I don't know how's the therapist situation in our community here, but therapy, I really think talk therapy works a lot for people who has no significant psych history, and like in this lady. And of course, you ask about suicidal thoughts, ideation, each follow-up visit. So this is just an add-on, a little bit about persistent depressive disorder. So we have major depressive episode. We have some people almost like chronically, and there's a whole thing. Sometimes people can be chronically depressed, but now having a major depressive episode. So we talk about this. And I think what's important that we already covered, when to refer to a psychiatrist, when to call 911, right? When there's active suicidal thoughts, when there is catatonia, those are the cases, especially with active suicidal thoughts, with very specific plan. If they tell you, I have been, you know, sometimes I felt, if we can just take the pill in it, or I can just be with my husband, I think it would be better. And you ask them, right, what is your plan? How far did you actually prepare the pill? Did you get the bottle? Did you think about what medication you want to take, right? Some people say, I want to just, honey myself. What did you think about how? You use the sheets, you use the clothes, and where did you think about doing it? The more specific their plan is more risky. When in doubt, call 911. Because in the emergency room, in psych ED, the doctor can always clear them And this is a case where you want to do more than less. And sometimes the patient will tell you, I don't really want to go to the emergency room. The children say, I don't think my mother's suicidal. And you educate them, right? You say, look, it's better to be safe. When to refer psychiatrist. When you give the SSRI after 4 to 6 weeks with adequate dose, but there's no responding, or the depressive symptom a little bit atypical, or there are some agitation, I think when in doubt, you should refer to a psychiatrist. I know a couple of psychiatrists, 3 psychiatrists in the community. They actually told me that when the PCP call them, refer a patient that needs to be seen by a psychiatrist, my understanding is that your patient don't even need an appointment. It's almost like a walk-in. I understand that there's a lot of a lot of patients help, but really our community psychiatrist giving the preference. If when you call, the PCP calls, I'm very worried about the patient, they will do their best to vet the patient, and they can start a meds, adjust the meds, and they probably will send it back to you if the once the patient is stabilized.
你得把这个帽子拿掉，等会弄湿。谢谢。
So before this slide, I want to just talk about it with our patient. There is one thing that we need to know. She's at home with a grandson, right? Let's say if the grandson is 7, 8 years old, and she's telling you she's very depressed, she can't help taking care of the grandson. You have to ask the detail. Why do you feel that? Are you falling asleep when the child is there? Is there anyone there with you, with your child? So when it comes to minor or geriatric patient, you have to make sure not just the patient is safe, the person they're care for is safe, right? Whether it's a very young child or elderly, right? Okay, so the next disorder, I just want a couple of slides since we're talking to PCPs and wonder if they're OBGYNs. One of the things is premenstrual dysphoric disorder, just a few words. So this is a menstrual cycle. This is a disorder that happens in the luteal phase, right? A few days before their menses, where they have some mood symptoms, anxious, irritability, liability, mood swings, but to a point cause impairment. So what I have on the bottom is very important, that irritability is the most common symptom, and symptom has to present the most menstrual cycle that occurs in the previous year. If 1 month your female patient coming to you with this complaint, you really want to monitor. They can do a mood journal. Tell them that, make a journal for the next couple of months, let me know. And it has to cause some kind of significant distress, interference with your activities. They call in sick, they don't go to work, and they're in bed for 3 days, this kind of thing. This is basically a very important slide. When do you treat? When do you not? Right? If there is no severe or moderate dysfunction, impairment in functioning, then you probably do lifestyle measures. Right? If yes, then this patient should be in hormonal contraception. If not, and you try SSRI. And these are some of it's basically summarized on that slide. If you take a look, this is a common SSRIs we use, citalopram, right? What do we have to worry about? We worry about QT prolongation, right? More than 40 milligrams a day. Citalopram, which is Lexapro, is a very nice, gentle. You start very low, right? or a Chinese patient, I don't even start 5. I do 2.5. Take a half. You can go up to 20. Prozac, fluoxetine, 10. You can go up to 40. But this is a medication has very long half-life. So when patient even stop medication, it's in their system for a long time. Paxil, and one of the things that we like to use for PMDD is sertraline. It's a Zola. And you can start 25 or half of 25, start 12.5, go up every 2 weeks or so. And I don't usually, it's hardly to see 150. I mean, with our patient, we'll do 200, 150, 200. But for PMDD, I would say 50, 75. Okay. Insomnia, this is sort of one of the complaints the patient has. And here, it has a lot of scales, right? You have to use a different type. It's difficult to fall in sleep, it's difficult to stay asleep, or frequent awakening, early awakening, a different meds for different stage. And in psychiatry, we actually would say the first treatment is really sleep hygiene, right? Is a patient going to sleep at the same time? Are they exercising? Are they on their phone before bed? And we use a lot of cognitive therapy, right? And I remember I have a patient who keep telling me he cannot sleep. And then I find out that he's taking dangui, he's taking the soup the night before he go to sleep. And with right dates with all the herbs. And no wonder he cannot sleep. So you have to just do the assessment. And for us, we use, at least in my practice, we use a lot of melatonin that people seem very fond of. When they say, oh, 脑白金, oh, 这是自然的, it's natural, it's over the counter, and there's extended release now, right? There's 5 milligrams, there's even 2 milligrams, and I know some people actually use gummy, which is a melatonin, I think 2 milligrams with chamomile, lavender, which is, they really like it because it's so natural. And there's the bilayer melatonin that not only induce sleep, but maintaining sleep. The next level we like to use is the trazodone. Trazodone, we start usually at 50 milligrams, and at the higher dose, right, it's an antidepressant. However, for the lower dose of 50, and we sometimes patient have a partial response, we can push up to 100 milligrams. I see trazodone works very well when we have a run around. We do not like to use benzo, which is, I think, it's one of the things that we want, like the PCP know. Benzodiazepine really should be, we have to use it very cautiously. Right? It links with, research links with dementia, and mainly for elderly population fall, right? People fell. And then it's not to even mention that it's habit forming, and they want more and more and more. They develop intolerance to it, right? Before, Ativan 0.5 milligram works, Xanax 0.5, now it's 1, and 2 years later 2, and then 2 milligram, 2 BID, TID, and it's really, with benzo, you have to be really monitored, and should be the last resort. So this is a very complicated slide from up to date. Sleep hygiene, this is actually quite important, I think, for PCPs, right? Because most of the time you find out they're doing things that lifestyle can be adjusted in terms of helping them sleep. For example, no coffee, no tea after a certain time, exercise. All right, we said this already before. Adding medication, the key is, I think, especially for PCP setting, is to encouraging. I'll have a patient tell me, I use hot water to soak my feet, it works wonders. And it really did, because we tried so many medications, it didn't work. And he does that, and when I recommend to other patients, also helps. So you go to sleep only sleepy, use the bed and bedroom only for sleep. If you're in bed and unable to sleep, you get off the bed and return only when sleepy. Get up the same time in the morning, regardless of how much sleep was obtained. Do not nap during the day. Okay, we'll talk about this already. In my time, common use meds in psychiatry, we talk about this already. We don't recommend Benadryl, but I see a lot of community patients like to use Benadryl for sleep. Okay, so I'm not making everybody bored, right? Okay, all right. All right, so this is the case two. You have I'm so sorry, I don't know what happened to the slides. I think the 56-year-old male, married with adult son, live with the wife, come to your office, complain about chest discomfort and shortness of breath, and telling you that I think I have pretty serious cardiac problem, and at the same time, pain in the abdomen that he's 100% sure. Okay, thank you. Okay, so he's 100% sure he has the cancer, and it's the worst cancer possible. Most likely it's pancreatic cancer. So he tells you, I think I only have less than 2 months to live. And at the same time, he said he worries a lot about his finance and how his family gonna do if something happened to him. He said he has pain all over his body and joints. By the way, the back pain is about 7 to 8 out of 10. He said he has difficulty to fall asleep, has early awakenings, feeling very nervous, edgy, and basically felt like he will die soon. Everyone's a little just. I'll just use the okay, thank you. Okay, great, this is better. So if the patient has a cardiac problem, patient has cancer, or the patient has, he said he's short of breath, he has asthma, does he have COPD? Or is he having a generalized anxiety disorder? I'm sure you see this a lot in our office. If all workup is negative, perhaps this is a patient suffering from some sort of anxiety disorder, right? Especially somatoform disorder, somatization, or what we call the anxiety is general illness. Right? I'm sure you see people, they won't come to see psychiatrists. They will not. They feel psychiatric illness occurs, and there's no issue with their, it's not depression, it's not anxiety, it's just the multiple medical complaints. Let's talk a little bit about anxiety. I think actually this is the one, probably this is the patient come to your office a lot. So we have a general anxiety scale, right? This is feeling nervous in the past 2 weeks, not being able to stop or control worrying too much about different things, trouble relaxing, being so restless that it's hard to sit still, become easily annoying or irritable. Their family will tell you they're irritable, feeling afraid if something awfully might happen. This is a patient always think he or she is dying. So this is again the DSM-5 of anxiety, excessive anxiety. Really, anxiety is worry, excessive worry, fear, right? And they have difficulty control their worry. And they usually, like we just mentioned, they feel fatigue, irritable, they have muscle tension, they can't sleep well. There are general anxiety disorder, there is anxiety with different types, right? Anxiety worrying about having panic attack and panic disorder,
there's social phobia, and there's OCD. And with children, separation anxiety disorder, post-traumatic stress disorder for our vet, right, come back from war, anorexia nervosa, the weight, eating disorder. What you need to pay attention is the last two, where somatic symptom disorder is perceived appearance flaws in body disorder. Not so much a body dysmorphic disorder, that's more about appearance. But what's in PCP's office I think is quite important is the somatic symptom disorder and the anxiety of having a serious illness anxiety disorder. Illness anxiety disorder. And I will tell you the difference. The somatic symptom disorder. Somatic symptom disorder is a patient are pretty adamant they have a serious illness, and when they go to you and you say, no, I did all the workup, you don't have pancreatic cancer. We did imaging, we did lab tests, no, and you don't have other symptoms. And that patient will go to a different doctor, until what they are searching is someone to conform their physical complaints. That's called somatic symptom. Now, illness anxiety disorder is someone that is more affected. They are more anxious. They are about everything. My back, my stomach, and I have a little pain, and I think that's the beginning. Let me read about cancer pain, things like that. So we'll cover more. The disturbances are not due to a substance or another medical condition, such as hyperthyroidism. And so DSM-5, again, this is our go-to manual about diagnostic for illness anxiety disorder. So preoccupied with having or acquiring a serious illness, somatic symptoms are not present, or if present, are only mild in intensity. If another medical condition is present, or there is a high risk for developing a medical condition. For example, my patient said, my father dies at age 54 from a heart disease, and that they're very, very preoccupied with that. My heart, they need every 3 months, they need to see cardiologist, they need to be clear, they're fine. It's clearly excessive. There are two types. Either they see all the doctors, and they want to see you very often, or they absolutely do not want to deal with this doctor at all. So there is a high level anxiety about health. The individual is easily alarmed about personal health status. They're the one checking the blood pressure like 5 times a day. Illness preoccupation has been present for at least 6 months, so you need to be at least 6 months. And the illness-related preoccupation is not better explained by another medical. We talk about that, right? So there are care seeking type. There are medical care, including physician visits or undergoing tests and procedures are frequently used. It's excessive. And there are care avoidant type. Their medical care is rarely used, right? You have 72-year-old female, never had mammogram. I don't want to deal with it, and I don't want to think about it. It's actually that's a severe anxiety presentation. Here's another patient health questionnaire 15. This is definitely something that you can see, right? Stomach pain, back pain, pain in my arm, in my joints, menstrual pain, headache, dizziness. A lot of complaints is kind of vague, right? I feel dizzy. I feel nauseous. My chest hurts. Fainting spells. Feeling your heart is pounding or racing. Shortness of breath. Pain during sexual intercourse. Constipation. Loose bowels, diarrhea. Nausea, gas, indigestion. Feeling tired. Having low energy. Trouble sleeping. Multi-organ, multiple system involvement. So somatization, it's really about repeatedly checking one's body for abnormalities and avoiding physical activity. And here are they very sensitive, high sensitivity to medication side effects. They're seeking care from multiple doctors for the same somatic symptoms, almost like they are looking to conform what they believe they have. And a lot of times, our doctors find very frustrated, right? I told you, I explained to you, we did blood work just last month, you're fine. And then one of the key things is that the patient refused to grant permission to speak among the doctors because, you know, it's, I don't really want the new doctor to talk to my old doctor because my old doctor already said, I'm crazy, I'm not doing, I don't have anything. I want a new, I want a fresh eye, I wanted somebody to diagnose me. And they will show you articles, magazines, Google search, where that someone's diagnosis of cancer was missed. And okay, so this one is quite important about if you think something serious wrong. This is the 7 items that sometimes we ask, right? Do you worry a lot about your health? Is it hard for you to believe the doctors when they tell you there is nothing wrong? A lot of times they don't know the doctors, they miss something, or it's too early of the diagnosis. They're the one always want MRI, multiple. Can I get a body scan, head to toe, right? Are you having many different pain? Are you experiencing many different pains or aches? Somatic symptom disorder, we went through this. And basically, they think they have very serious illness, they're worried. Patients previously diagnosed with hypochondria are nearly always diagnosed with either somatic symptom disorder. This is with the physical complaints that are prominent, where they're searching for different doctor, or illness, anxiety disorder, where the physical complaints are minimal. However, they believe they're sick. Somewhere, something is very seriously wrong. Okay, so persistent and resistant worry. APA guideline, the good news is the treatment for this is basically like the depression. We use SSRI. I mean, when the point comes that patient want to see you so often and so their life is preoccupied with anxiety that something's wrong, I think at that point we should try some SSRI, right? Like Zoloft, Celexa. And again, sometimes in this case, you might need to use some benzo because it just they can't, even for SSRI to start kicking 6 to 12 weeks. At the beginning, you might need to add a little benzo. We prefer long-acting, which is a lesser possible for abuse, like clonazepam. Okay, so yeah, put a little notes there. Clonazepam is not clonazepam for short-term release, as it can be metformin. So you can use a 0.5, or I see people use half of that, 0.25 PRN. This is another busy slide. Basically, final tips that patients with depression and anxiety can often show up at primary care physician's office with somatic complaints. Those are depression's core symptom, depressed mood, and lose the interest in activity, lose the enjoyment of the activity they really like, right? What we call anhedonia. Those two things are important. And they have to cause some kind of impairment in their functioning. And of course, suicidal ideation with a plan, with very specific plan, with an intent. They want to die, they have a plan, they will die, and including people write wills and start, I'm trying to make sure my financial business are in order, so I can give to. With something like that, you need to be on high alert. if it's a very specific plan, 911 should be called, and it should be referred to psychiatrist ASAP. Anxiety symptoms, we cover most about excessive worries, and there are different type ones for PCP, especially illness anxiety disorder and multiple somatic complaints. Just keep in mind on that. A lot of our patients really just loving tender care with reassurance, right? We did this test, educate them, we did blood tests, we did imaging to refine, and also that a lot of times it's actually just, I think the patient just want to see you, to hear from you, you're okay. Suicidal thoughts, we said, that was 911. I hope this helped. Thank you. I don't know if any questions.
Thank you, Dr. Wang. Yeah, it's very informative. Yeah, I learned a lot as a PCP. So things our agenda move a little bit quicker, so we have more time to have some discussion with Dr. Wang. Yeah, so any questions? Yeah.
Thank you, Dr. Wang. Thank you, Dr. Wang. Great lecture. Yes.
Dr. Wang from
One family today.
right? Yeah, Dr. Wang from Maimonides, right? Sure.
Yes. Very, very nice lecture. Learned a lot. And the first time I've heard premenstrual depression disorder. We all heard the postpartum depression disorder quite often, but premenstrual, never heard of it before. What do you think the mechanistic, which hormones are driving these changes, or driving this depression feelings or symptoms? And what happens to women postpartum, post-menopausal? Do they still have depressive episode when they are cured after the menopause?
Yes, thank you, Dr. Wang. That's a very, very good question. First, I just want to say that you mentioned about postpartum depression. I didn't cover here because I thought this is more for primary care doctor. The postpartum depression actually sort of really should be bumped to a psychiatrist, right? Because postpartum depression, a lot of times it's, to us, an indication that the mother actually had a bipolar disorder or major depression, and especially at that time when the baby just born, and this is a very trying time, right? They don't sleep well, and they're dealing with a lot of stress. That is and you also tragic cases when people become very depressed and did things to their children. So that is for postpartum depression, especially with psychosis. We have to assess if there's psychosis, and that is really, I think, my personal opinion, should be referred to psychiatrists. That's a little bit more complicated to managing. So the next question is about what we talked about here, premenstrual dysphoric disorder. For postmenopausal women, yes, there is actually it's the hormone progesterone estrogen change in the luteal phase, right? We have let me see if I can go back. There's a graph. Here we go. So it's in the luteal phase. It's the right before menses, usually 5 to 2 days before. So at that time, you can see we can see the different hormones at that time, right? Mainly is the progesterone, the estrogen change. So that's that. And for post-menopausal, that was a very good question, right? Now with PMDD, we know before menses. What if patients post-menopausal? What if patient who had hysterectomy? We don't actually have the menses as a timeline. How do we know? What we recommend usually is a mood journal, right? If for example, I know people who had total hysterectomy, right? You can actually know. I did. I had a total hysterectomy. I still have one ovary, But I can feel, even though I don't have menses anymore, there are certain times of the months. You can realize your mood is kind of low. And then what you do is you tell patient, like my case also, my GYN told me, you ask them to journal, right? This month, when I feel pretty low, oh, it's the 25th of August. Let me circle that on my calendar and let me see how my mood, when will be the next time in September. Let me pay attention, plus minus 25th, which day I'm going to feel kind of, down or kind of irritable. And then when you tell patients you tell them to do a while, like 3 to 6 months, which I do that all the time with my patient. It's just like a depressed patient who you ask them to do happiness journal. It's the same thing. You basically want to use very objective data. And also to remind the patient, you know what, next in October, on the 20th of October, you might feel bad. You might feel kind of like nothing works, and you can help patients do that too, right? So we recommend mood journal, and I'm sure, I don't know if GYN can take blood work and to see the hormonal level, but in psychiatry we do the journaling.
I don't want to hog the microphone, but I can't help but asking follow-up questions. So are there any treatment designed based on this theory of hormonal changes to prevent or treat these?
Yes.
Okay, good, that's great. Maybe we can learn more later.
Yes.
More details.
Yes, absolutely, yeah. PMDD, I think the first thing is that you ask the patient, right, if they're causing significant impairment, you ask them that, are they willing to be on oral contraception? That actually, my understanding, solve a lot of PMDD issues, yes.
Great, good to know. The second follow-up question is regarding postpartum. You mentioned that people who have postpartum depression are prone to be diagnosed with bipolar and depression disorder. So, what's the association with how likelihood is that's going to be the case? They have existing condition which is not identified, or they have first-time event, then they become more depressive, afterwards.
So
Or long term.
yeah, so with the postpartum depression, I think it's a very complicated issue, because most you can imagine, I have 3 kids myself, that is a very sensitive time, right? Like you don't sleep enough, you have to feed the baby every 3 hours, and you're tired, and suddenly you realize you have a responsibility for the lifetime, and for this little child that you just give birth. So I don't want to say that there are normal mixed feeling. There's a normal depressive feeling. I don't want to say that right away. It's when we find that when they start having some psychosis, when they are like hallucinations, when they are or they're just in bed with severe depression, right? Or we mentioned about catatonia. Sometimes if they're not moving, they become mute. This is kind of thing that you want to watch for. I mean, postpartum is a very sensitive area. Most people experience very mixed feeling, but it's when they are started not functioning, and because also there's a baby involved, so we're very careful about it. I don't know if that answered the question. I just want to, more or less. Thank you, Dr. Wang.
Thank you.
Hi, good morning. Thank
Good morning.
you for the talk. So what I want to ask is, in your opinion, is there any well-justified relationship between vitamin D deficiency and depression? And if so, what could be the underlying mechanism for it? Thank you.
Thank you. That's a very good question. I didn't really talk too much about supplements. I have a colleague, Dr. Wang, who's actually really know a lot of, who's a psychiatrist in the community and who knows a lot about the supplements. The first part of the question is yes, vitamin D is absolutely we use for depression and as a supplement. Second part, the mechanism behind it, I'm not sure. That I'm not sure. We use vitamin D, we use fish oil, and there was something else we sometimes we use. So there's quite a few. I mean, in general, when patients come to us, if they have not been on multivitamin, we do give multivitamin, and definitely vitamin D. Yes. Thank you.
So at our PCP, we do encounter quite a few perimenopausal women patients. They experiencing hot flash and trouble sleeping, very very disturbing, and dysphagia cost of the life. And so I think we tried the fluoxetine with a pretty good response. Do you have some like tips how to safely prescribe this medication for the perimenopausal patients?
Thank you, Dr. Wang. So in psychiatry, especially with outpatient, we always say when we start any medication, our module is start low, go slow. I think there is a branch in psychiatry, women's psychiatry. So a lot of them dealing with pregnancy, lactation, and also perimenopausal. So I personally do not know if there are very specific guidelines for that period, but in general, we start, and I find especially with my Asian patients, I have some Korean patients, some Chinese patients, they turn to be, you have to really start very low, and sometimes the half of the beginning dose, and then you give them 2 to 4 weeks, you monitor them. If they don't want to come in, it could be a phone contact, right? Or in psychiatry, we do video sessions just to check in to make sure 15 minutes max check and they're doing okay. And then slowly increase. Yeah. Thanks for good.
Thank you. Any other questions?
I think I have to take this opportunity to ask all that question.
Thank you, Dr. Wang.
I didn't get paid. I didn't get paid to ask questions. So you mentioned that the tricycle has fallen out of favor, for first-line treatment for depression and anxiety. What about for insomnia and anxiety, insomnia? We often encounter a lot of issues related to that. So, we as neurologists have been using the tricycle as the not necessarily first line, but in combination with these factors or symptoms as a decent, effective medication. And also related to long-term use, there's dependency to that too. So what is your take on when to use it and how much and how to say avoid it or to get the patient off those stress active if we need to.
May I ask what type of tricyclic, what medication?
We typically use nortriptyline or amitriptyline. Yeah.
Oh, okay. So with the tricyclic, our issue is we're worried about, we're dealing with depressed patients, right? Or patients who cannot sleep and so on. We're worried about overdose. Really, that's what we're worried about, right? We do deal with in psychiatry, like in terms of what people overdose in Zoloft or overdosing Lexapro compared to overdosing tricyclic, right? I'm sure you cardiologist. So that's really for me. We don't. When I trained already, the tricyclic we don't use too much anymore. Yeah. Only because the overdosing is real bad.
Thank you. I think I have to ask another questions. I wanna request to ask the same number of questions with Dr. Tony Wang. Yeah. So regarding the suicidal, which is a major concern for the PCP, when we kind of like have any encounter with depressive addictions. When I was in the medical school or like a residency, that psychiatric attendant was mentioning about the suicide contract.
Yes.
Do you still recommend it or any?
No.
Or not
Yeah,
anymore?
not really, yeah, suicide contract, the research shows not really, it was very big back then, and I mean, I shouldn't say it's not a guarantee anymore, especially this, I can see in PCP office, patient doesn't want to go sent to emergency room, right? So what they say is, sure, I'll make a contract. What we do right now is what we call the Columbia Suicide Scale, that you actually, it's called Suicide Safer Care. You give them, it's a piece of page where you say, what are your triggers, right? Some people say, like in the first case, she probably say that when I look at my husband's picture, when I feel bad is when I see his picture or when I pass a place, a supermarket we used to go to. Something you firstly need to name the trigger. Second is when that happens, what can I do first for myself? So she will say, I can pray, I can pray, or I'm meditating, or I try to watch TV to distract myself. And the next thing is, who else can you call? I can call my daughter, I can call my son, I can call my people I met at senior center, I can call my sister in China. So you want her to have that. And then the last one is, who else can you call? Patient can call the psychiatrist, the therapist, or caseworker, case manager. You want them to have this piece of paper where when this happens, hopefully they actually remember. If you don't, they can look. What we find is a suicide contract, a lot of times really when somebody really want to kill themselves, really no one can stop them, right? The last thing is they really are suicidal, they don't want to be in the hospital. What you can tell them is that, mood come and go, right? 情绪是可以，有时候有时候可以走的，就是很正常的。现在，I'm so sorry, I'm speaking Chinese, but it's quite normal, right? Right now she feels depressed. This is only 4 months, and they're married many years, right? Every day go by, you're gonna feel a little bit better. Some days you're gonna move forward 2 steps and come back 1 step. But you have to give some time, right? Life is precious. When you are depressed, you think suicide is a solution. When you are not depressed, that's when you can make a decision, right? Because I have patients tell me, it's my right, it's my life, I'm suffering. If you could be in my shoes for 1 day, you know what kind of life I'm having. I have a patient with permanent jaw pain after a car accident, no matter what they did, cannot be resolved. She goes, if you live in my shoes, and you walk in my shoes 1 day, I promise you, no one will live, right? Isn't it my right to decide when I don't want to live, right? I'm here so I can find people who help me to die. I think, you have to, we're not going to say, yeah, you have a right. We're going to say, like, you have to try different things. When people depressed, they make a decision. It's not really a decision. That's what it's very, for us, suicide is like usurpation, right? To you, so suicide is a big, heavy topic, but have to be dealt with. There's so many things involved now. Suicide contract before, now suicide skills. And we do the safer care. To us, it's like with you ask blood pressure, vital signs. For us, it's left and right, up and down process. Suicidality. Suicidality and homicidality, right? I work in state, so we're dealing with people like pushing people in the subway and because of voices, because of pollutions. So that's kind of saying, well, people who kill their whole family, or whatever, so.
Thank you so much.
Dr. Wang, thank you for the lecture. It's very helpful. So as a primary care doctor, we take care of a lot of elderly patients. So whenever we prescribe patients, the medication review unit always send us it's on the bear list. So other than melatonin that is over the counter, any recommendations for elderly patients who just can't sleep?
Thank you. It's Dr. Hong, right? Dr. Hong is my parents' primary care doctor. Yes, they love her. Thank you for taking care of my parents. Yeah, for elderly patient, so you said melatonin is not working and they're still not able to sleep. Do we know, are they having problem falling asleep or staying asleep or early awakening? So I mean, there are I'm sure you use Lunesta, Ambien. It's not really recommended for elderly patients. Sometimes we use clonazepam. We use a little bit benzo. But for psychiatrists, if I see, let's say, a 72-year-old in my office, I would try trazodone first. If melatonin is not working, I'll try trazodone. Trazodone, they start about 50, I would say do 25, cut a half. I have patients even do quarter, right? Let them go slow, and trazodone seems to have pretty good effect. That's not like a Remeron cause the next day drowsiness, and also it's not a benzo, so the risk of falling is a little bit less. No worries. Ambien is, we have to work. Ambien and a benzo is something we want to wait, but I'm saying, like, I don't cover nursing home, but the geriatric psychiatrists at my work, they said that a little bit benzo is okay for elderly. And I don't live, let them be peace. Thank you, Dr. Hong.
Hello, I have a question. I do use trazodone a lot for my patients for insomnia and depression. Some of them have like a lightheadedness, like a dizziness after taking that. So if the trazodone is not working, what is the other medication do you recommend for insomnia? Because it's a very common issue. Of course, sleep hygiene is the first thing to talk about it, but they usually don't listen to you. They skip watching the TikTok or like a WeChat, like I get very late. That's very common.
Thank you, doctor. That's a very good question. I know. So melatonin is not working. Trazodone is not working. And you mentioned about, or they feel, I think you said dizziness, right, or lightheaded.
Yes, I have a couple of patients. They feel like, after they take a trazodone, I cannot take it. I'm feeling so lightheaded the next day. So
How many days since they felt that way?
So why they feel the side effect, they don't want to take it again. They say, I cannot take it. They say.
I see, and that's with 50 or 25?
I usually start low, like 25.
25, yeah. So when it comes to side effect like that, our answer usually is wait. Wait, and wait, yeah.
Continue to take it and
yes, absolutely, yeah. I would definitely at least give a week for trazodone, that low dose, and I would say, the main thing is to engage with the patient, right? So can you try to take a little bit earlier at night? Did it help at all, or it's just in the morning that you feel lightheaded? And then maybe we can even cut half of the 25, or do quarter of 50. That sounds like a side effect can wait. I would give a week.
Yeah. How long does it take to work usually, for the
trazodone? Right away.
Right away.
Yeah, right away.
Okay.
Right away. Yeah, right away. I mean, like I was saying to Dr. Hong, if the patient really has a lot of, like if you see a lot of worries, the elderly, we don't recommend, to use the benzo. You can also give them a benzo during the day and to see if they get the anxiety down a little bit, right? Or actually SSRI, right? Paxil is quite sedating. You can try that, and for the anxiety, it's one bird killed one stone through two birds, right? You give a little bit Paxil at night, try, we work 24 hours for the anxiety, but at the same time help them sleep. You can do, yeah. But with the trazodone, if they say that, I would say wait and wait and wait.
Okay, thank you, thank you, thank you
You're
very
welcome.
much.
Are we still using the Buspar or Hydroxyzine for the anxiety?
Absolutely, that's a very good question. I thought, that's very good for PCP. Buspar, absolutely. I find mixed results with Buspar. Some people said absolutely works. I have a young patient, a young lady in her 20s. She's only on like 15 and it works. But then I have people say Buspar really doesn't touch their anxiety. But that will be a good thing to try, absolutely. I don't know about how much it helps sleep, but yeah. Yeah, welcome.
For trazodone, I've used trazodone until I was diagnosed with sleep apnea. So there's two things I wanted to bring up. With trazodone, I noticed that it was working when I felt heaviness. When after half an hour, as soon as I lay down, that I would feel sleep. So, and it's, I would recommend using it with I'm a psychiatrist. I would recommend using it with food, not in with the stomach, because it affects serotonin and cause severe constipation. And the other question is, what about sleep apnea? So like as soon as I was treated with the CPAP machine, I didn't need the trazodone. And I think there's studies that show that 40 to 60% of people over the age of 60 have high risk for sleep apnea, even without snore. And it can contribute to many other diabetes or weight gain. So the sleep apnea is high. I think it's probably still underdiagnosed. But also the treatment, but from doctors who have a friend who treats sleep apnea. But I think the statistics are something like 50% of the people who are prescribed a CPAP machine don't like that CPAP and refuse to use it. So there's other treatments. The CPAP is a think about also.
Thank you, Dr. Schuster. Thank you, Dr. Schuster, psychiatrist also. My husband come to support me today, but thank you, that's a very good question. So one of the things he said is that he actually tried trazodone, and he said trazodone make him feel very heavy, and then he fall asleep. So one of the things you can help patient to do, he said, it was much better tolerated with food. So take the you can make sure the patient take the trazodone with food. So that's something that you can recommend. And the other things he mentioned about sleep apnea, right? I'm sure in our APA meeting, psychiatric meeting, we said sleep apnea is actually one of the contributing to dementia, right? So it's very important that you refer a patient for, sleep study. In his case, with a sleep apnea machine, he no longer has sleep issues. So sometimes the sleeping issue, is it just anxiety, is it depression, or is there any physiological cause? And yeah, that's a very good point.
So my question is about psychodermatosis. I'm a dermatologist. Sometimes I do see patients who come in with bags which contain pieces of skin that they literally they pick up themselves. And they tell me they swear they have bugs crawling all over their skin. For these kind of patients, if I cannot get them to see a psychiatrist right away, what would be your recommendation of a medication that has the most favorable side effect profile? And if I do start, what sort of side effects I should watch for or monitor? Thank you.
Thank you, very good question. So I think what's important is to see, is this psychosis? Is this just severe anxiety? Is this just a severe anxiety, or this sounds to me a little bit on the psychotic spectrum, where they don't really, it's actually one of the sort of hallucination we call. And after you explain, there's no other mood symptom, right? No depression, no severe anxiety, just to come to you to say that there are bugs, that they don't actually have bugs, right? You already make that determination. I would try a little bit of resveratrol, and I would do very low again. Has patient ever been a psych meds before? No. I would do, or lowest dose is 0.5. I tell patients do half of that, 0.25. And also I want to watch the OCD symptom, which is on anxiety on the mood spectrum, right? Where is a patient keep washing hands? Where is this coming from? Like, what is he or she think? What kind of bug? I know it's hard, right? We all rush, but this is the case. I would refer psychiatrist at the same time start treatment.
It's always very difficult to persuade them or to explain to them, this is not something, that if it's unfounded, basically, they will take it as being very offensive. Do you have any recommendation of how I should approach them with that recommendation that you should really see a psychiatrist?
You can say psychiatrist is just like somebody to talk to. It just means that they can help you. There maybe, you can say, I'm an expert in my field. This is not reality. Like, it's really the definition of delusion. When you believe in something, that's not reality. So what you say is sometimes we're anxious, sometimes we're worried, we're, how we feel physically sometimes is a manifestation of how we feel inside. It's not so easy, especially with the younger patient. Get a psychiatrist will help you, talk with you, to help me as a dermatologist. We can attack this issue together, because you're obviously very bothered by it, and present a psychiatrist, someone that you can talk to. That it doesn't mean you have any mental problem. Everybody at different phases in our life, different stage in our life, that we have worries or we have things that we need to figure out. In this case, I'm not really sure, how to explain to, or I think it would help you have a psychiatrist to talk with you. We always start with talk therapy. We come in, what do you want to say? They can say, I don't want to be here. My doctor sent me here. I really want to be here. Okay, tell me more about it. Tell me a little bit about you. Tell me what's worrying. What's your doctor's worry? And thank you for coming. And you go from there. I think everybody enjoyed a little chat at times. I think it's hard for us because I have patients who tell me, psychiatric illness is like a curse. We don't have this. This is not, No, it's not. It doesn't have to be an illness. I represent as maybe like a help along your way, right? We want our patients to live their life to fully. Whatever their dream, whatever they want for their life, we're here, we're a cheerleader to help you get there.
Yes, I'm a PCP. I would like to know if a patient has dementia with behavior problem, what do you treat? And is this serial is a role to treat that?
Very good question. Very good question. I see in the hospital the use of when we do CL, cerebral got used a lot. Why? Because it's sedating and it's with dementia with behavior disturbance, we do use antipsychotic. I see how used a lot. I have to say CL is not my field, but there are people use haloperidol, very little, 0.5, 0.25, Seroquel, I see 25, and I see 50. I don't actually know fresh out of my head what is the APA guideline on what to use. I know you have to use a atypical antipsychotic, right? You try to now to use first line antipsychotic, you use the atypical. Seroquel is sedating, so you want the patient now to acting out. More important, I think, maybe look, we have for atypical now, we have some new ones. And we use that risperidol, we have Seroquel, we have Duradon, and we probably not going to use for geriatric patient. I don't know what to say. I think there are some new ones out there, might be better. But I see Seroquel being used a lot.
I think Rexulti is approved for agitation associated with dementia. I think it's
Rexulti is pretty good. Yeah. This is. Thank you for reminding me. So Rexulti is FDA approved, right? Dr. Schuster is FDA approved. I think that's one that's approved by FDA for dementia with behavior disturbance.
The problem is, this is my last question for you. We can talk with you offline. I have actually a comment, request, and the last question. Sorry. So I think sleep is so important in our lives, and we often underestimate the benefit, importance, and necessity of sleep, good quality sleep. I think Dr. Schuster is doing well. Once you have sleep, underlying sleep disorder identified and mitigated, then your quality of life is drastically changed, and we don't need actually the medications all the time. And so, from a neurologic psychiatric perspective, I think it's most important to identify the underlying cause, then treat that, and I think your symptoms will accordingly be managed, sometimes disappear. So I think I couldn't agree more. So based on that, my request for next year's conference is to actually have a topic on sleep medicine. And what's the disorder, and what is the treatment with the current guidelines, and what is available resources in the community? Because I refer a lot of patients with sleep disorder to Dr. Digley. I think he's the only one I know of, in the construction community who does sleep studies. Right, so we have very limited kind of available resources with experts, identifying and treating these patients. Right? But that's only sleep apnea, right? But insomnia and other sleep disorders are very important to include, especially in the geriatric population. So that's my request. The question is that what is your experience and treatment preference for seasonal adjustment disorder that may have something to do with vitamin D, especially I feel in general, people on the West Coast in California are a lot happier than the East Coasters. And kids who went to school or whatever wrote there never want to come back for some reason. So can you comment on the seasonal adjustment disorder and what's the best treatment for those, especially for people who have anxiety, depression disorder at baseline, and how to approach it?
Thank you. I agree with, we can never learn enough about sleep, right? This is one thing that we know it's affecting every part, every organ, and every aspect of psychiatry, internal medicine, cardiology, every part, right? So I agree with that. I think we should next year, we should get more topics and more, and more resources in the community to help internal and so on, sleep problems. For seasonal affective disorder, light therapy, Dr. Wang, light therapy. Yeah, this, I don't know if any psychiatrists actually do in office, but the official answer would be light therapy. Go out in the sun, go for a walk, and that would be.
All right, thank you, Dr. Wang. Thank you so much. Thank you, Dr. Wang, for giving us 2 talks at one time. One on slides, one during the discussion. Thank you so much. Yes, thank you. So if you have any further questions, Dr. Wang is not leaving, so absolutely you can have more discussion in person and offline. So we are going to take a break. So we can stretch, we can take some coffee, go to the bathroom, and also remember to stop by our wonders. Because without their generous sponsorship, we cannot have these wonderful events. And at the same time, we do have a raffle like at the end of this convention. So make sure to get the ticket from the registration desk. And you stop by each vendor, and they're going to stamp on your raffle ticket. At the end, we're going to have some like a surprising prize for you guys. All right, so please come back on around 11:10. So we're going to have a very, very interesting talk about AI in medicine. So I'll see you guys around 11:10. All right.
Can you come here? 1 second, sorry.